That is very sweet.
I feel a little selfish in reading that, but thank you to whoever 83968675309 is.
Love that one.
Welcome once again to Free Associations from the Boston University School of Public Health, the Public Health and Medical Journal Club podcast for anyone who is as confused by the latest health study as I am by why clouds don't freeze.
Oh, wow, that's deep.
So this is an issue I've been made fun of a lot for, but I'm just going to confess it now.
Okay.
If you think about if you're on a plane and you look at that little screen that tells you the temperature outside, it's well below zero, even if you're flying in summer. Water freezes at 0 Celsius, right, or 32 Fahrenheit. So therefore, clouds should freeze. And therefore, I believe that pilots, when they're flying, what they have to do is they have to fly really fast when they go through the clouds to break through that layer of ice. Most people don't realize this, but I'm pretty sure that's what happens.
Wow. I've never thought about that, but this is something where I think Chris would have the answer.
He might, but I
think he wouldn't know. You've asked him already.
No, I've asked a bunch of people who know things about planes and who know things about meteorology, and I haven't gotten a good explanation. There is one, of course, there is. I'm kidding, by the way. I don't really believe that's what happens, but it has always made me curious. Why do clouds not freeze if the temperature is so cold?
I don't know the answer.
I don't know either, but one of our listeners can tell us. So.
Yeah.
I am Matt Fox from the Departments of Epidemiology and Global Health at the Boston University School of Public Health, and I am joined this week. We have only two of us. Chris is away, and so I'm here with Dr. Jess Liebler from the Department of Environmental Health at the BU School of Public Health. Welcome, Jess.
Thanks, Matt. Nice to be here.
And as a reminder, if you could head on over to the Population Health Exchange website at www.pophealthex.org, you can find lots of population health learning programs and tools. And also, if you can give us a rating on your favorite podcast app, iTunes or Stitcher, and we have a new review. So this one's a little self-indulgent because I get referenced in this one, but it says, this is from... Well, it's just a number, 9284839, bunch of numbers via Apple Podcast. It says, favorite Epi podcast. I love listening to this podcast. I'm an MPH EpiBio student at the BU School of Public Health, and this podcast keeps me abreast with the subject. The podcast is not only informative, but also funny with Professor Matt Fox. So,
that is very sweet.
I feel a little selfish in reading that, but thank you to whoever 83968675309 is.
Love that one.
All right, so now on to the show. So today in our first segment, which is our Journal Club segment, we're going to look at a study on pesticide residue on fruit and vegetable and risk of glioma. In the second part of the podcast, which is our deep dive, we'll talk about the rise of the preprint. And in our Amazing and Amusing, we'll get into some things that make us laugh out loud or we just were fascinated by. So let's jump in. So segment one, we're going to talk about an article that looked at the impact of pesticide residue on risk of glioma published in the American Journal of Epidemiology. Full disclosure, I am on the editorial board of AJE. And the study was titled Pesticide Residue Intake from Fruit and Vegetable Consumption and Risk of Glioma by first author David Coate of the Department of Epidemiology at the Harvard T.H. Chan School of Public Health right here in Boston, Massachusetts. I just want to say, I like titles that are short and sweet like this, that don't, there is something nice about getting the study design and the result and everything in the headline.
Colon,
but I don't know. I'm a fan of just a nice, concise headline title.
This was a nice title.
Yeah.
I agree.
So again, like with our last episode, no headlines on this one. This was one we were interested in. So Jess, can you talk us through this study?
Sure. I feel like we're continuing down our fruit and veggie path from last time.
We are. I feel like I should be eating a banana.
Right now. I know. This is a very interesting article. So just by means of background, gliomas are a rare but highly devastating type of brain cancer. And the causes of glioma are largely unknown, but are suspected to at least be part environmental, kind of related to some sort of environmental exposure. And occupational studies over the course of many years have demonstrated elevated incidence of glioma among farm workers, specifically pesticide applicators, and likewise high levels of pesticide exposures among this workforce has been associated with glioma in a number of studies. And there's also a solid basis of toxicological animal-based data suggesting that pesticides have an association with this sort of cancer. However, studies of dietary exposure to pesticides have demonstrated either a null association or a much weaker association with glioma over time. So this study is trying to add some nuance to this understanding where we have oftentimes, so I'm in the environmental health side of epidemiology, and often there will be studies in the occupational health literature that will be focused on high levels of exposure among a very narrowly defined and specific group of workers being associated with a particular health outcome. And then those sort of findings drive a deeper dive into exposures among the general population. And so that's what this study is doing, is they're kind of taking that step from some evidence from the occupational and toxicological literature and then looking to see if dietary pesticide exposure with a finely tuned assessment of pesticide level by type of fruit and produce and veggie is associated with glioma, with this particularly devastating but rare type of brain cancer. So these authors come from the Nurses' Health Study juggernaut. Is that the term?
I think that's a fair term.
Okay, so this study takes place within the Nurses' Health Study, which is actually a number of kind of interwoven cohort studies, and they are looking at the relationship between questionnaire-based fruit and vegetable consumption in conjunction with data on pesticide residues that are identified on those specific types of produce as established by the USDA Pesticide Data Program to consider the risk of glioma in association with fruit and vegetable intake. So their core hypothesis at the outset is that high consumption of pesticides on produce, so kind of elevated consumption of produce that had higher levels of pesticide residue on the basis of these USDA assessments, would be positively associated with glioma risk, but that low levels would be protective of glioma under the more general assumption that fruit and veggies might reduce your cancer risk. And so this was kind of an interesting kind of dual hypothesis at the outset. So there were at the outset about 200,000 nurses and healthcare professionals enrolled prospectively in the three cohorts that made up kind of core population for these studies. The original Nurses' Health Study, the first Nurses' Health 1, started in 1976. Then there was a follow-up cohort that started recruiting nurses, trying to get in part a more diverse population in 1989. And then in 1986, there was the health professionals segment of the Nurses' Health Study that started focusing also on recruitment of men and on people, not just nurses, but other sorts of health professionals. So there are hundreds of thousands of people in this Nurses' Health juggernaut that's being drawn from this study. These participants completed dietary assessments every 4 years using, as they call it, the FFQ, the 131-question food frequency questionnaire, which is highly validated and used, to my understanding, kind of widely across the nutritional epidemiologic literature. It has 30 produce items that they ask about, and response can be, I never eat this, to I eat this 6 or more times per day. And so people could respond to all of these different produce types and look at their frequency of consumption. And they aligned consumption patterns with pesticide levels as identified during the time period. So the USDA sporadically updates their pesticide data, their residue dictionary. And so what they tried to do here was to align the consumption patterns to the same data on residues on a strawberry, for example, at around the same time or as close as they could get to when that person completed that dietary questionnaire. Under the assumption, they made the point, which I thought was fascinating, that apples and oranges were the only pesticides where there was not tremendous variation in the pesticide residue over the study years. And so that was an important component of what they did too. They considered other factors in their models as risk factors for glioma, including BMI, physical activity, alcohol, other metrics of healthy eating. And gliomas were self-reported on questionnaire and then also physician confirmed, and deaths were confirmed through assessments through the National Death Index. So this is a longitudinal study. They were looking at incident glioma from the start of the study and produce intake from the start of each study until the end of follow-up, which ran from 2013 to 2016, depending on the cohort the participant was in. And the analyses were the cumulative average of intake across all of this data. And they used Cox proportional hazard models to estimate the adjusted hazard ratio of glioma by quintile of pesticide intake, specifically looking at the highest and the lowest quintile. So what did they find? They had across 2.8 million person years, which is why you got to love the Nurses' Health Study, 275 incident gliomas reported in that person year package. And again, that really reflects how rare this outcome can be. Within the first, and their results varied by cohort. which was interesting. They had these 3 distinct cohorts. In the first cohort, so these were the nurses. They were almost entirely white women. They were recruited in the late 70s. They observed a strong association between the intake of the highest pesticide produce and risk of glioma, with their hazard ratio approximating 3. In the second cohort, a negative effect was seen with the highest pesticide level, although this effect was not statistically significant, and they basically saw a null effect in the third cohort.
And just to point out, they interpreted the protective effect, because it was not statistically significant, as null, which I take a little bit of an issue with. Although, I mean, their confidence interval is very wide, so fair, but we'll come back to it.
Yeah, so no, that's a good point. And the pooled estimate that they looked at was about 1.4 across all the cohorts. And they didn't find any specific food items that they thought were driving the relationships that maybe had changed, their pesticide residue level had changed during the study period, or certain foods that people who had glioma were more likely to eat. They didn't find any of that. And so their conclusion, and we know that Matt loves it when the study authors, kind of dictate their own conclusion, but what their conclusion here was that in the 1976 cohort, their original nurses' health cohort, which was all nurses and the study was predominantly white, there was an effect between exposure to dietary pesticide residue and risk of glioma, but they did not observe this effect in the other cohorts, which had slightly more diversity as well across kind of demographic groups and also across healthcare professions.
Yeah, so I thought this one was an interesting puzzle, because, if this pesticide does have an effect, it's hard for me to understand why that effect would effectively disappear in a more diverse cohort. But I think there are some possible explanations that we can talk about. To back up, I always start off by, writing down what's my prior on this. And I thought, well, I don't really know this topic all that well, but my prior is, I suspect there is probably an effect. I don't know how large it is, but I suspect there is an effect. And then I started to interrogate that a little bit and think, well, why is it that I think that? Because again, this is not an area that I study. This is before I read the introduction, when it's clear that there is a sound basis for this. But I think the reason is, I think I have an a priori belief that if we're talking about something like pesticides, there is a reasonable chance, not a high chance, but a reasonable chance, a non-zero chance, I should say, maybe not reasonable, but a non-zero chance that it is associated with pretty much any cancer. Not because, I have a biologic mechanism in mind, but it's just sort of that is sort of where I start from. And I don't know that that's really justified, but I think that we, as humans, are conditioned to believe that things that we don't, pesticides are probably, have the potential to be harmful.
Many of them are carcinogenic.
Sure.
And so I think your understanding is not out of thin air. It's not out of thin air. It does come from, many of these chemicals are demonstrated in repeated studies of animals to be carcinogenic.
Carcinogenic, yes, but the question is in the kind of doses that would be consumed, right? So in farm workers, it seems to me highly plausible. When you get into pesticide residue, I think, my level of skepticism goes up. Not that it couldn't be having an effect, but that the effect would be much smaller if there is an effect. Right.
And I think the question becomes, if there was a smaller effect of residue, is this the population in which you might see the effect? So is this are largely adult women, kind of the if you were making a claim that this dietary pesticide exposure causes health impact, would this be the highest risk population? And the answer is probably no.
Who would be?
Children, maybe. But the challenge is you couldn't really look at it would be very difficult to look at a cancer outcome in children. So the longitudinal nature and the almost 3 million person years, for example, in the nurse's health is the perfect situation to look longitudinally at a cancer outcome, and especially an outcome that is just so rare, where you have only 275 cases among 200,000 women. But there's challenges, because you could say maybe these are not the people. If there is a biological effect, maybe these are not the people where you are these are not the most vulnerable people. And actually the period of importance might have been during childhood. If you have a cancer that might have a 30-year latency period, Even if, nurses' health is looking over 10, 20 years.
I think you're absolutely right. I mean, so part of what I was going to get to when we talked about, why might you see differences in these different populations, even if the biologic mechanism is essentially the same, part of it may be that these cohorts on average were different ages.
Yep.
And the younger, I think it was the one that was the youngest on average where you saw the smallest effect. I think it's worth pointing out, you said, millions of person years and like this is something you could do in the nurse's health study, and isn't this great? And it is, but it's also worth remembering that your precision is driven not by the number of person years, but by the number of events.
Right.
And so you've got millions of person years, but only 200 or what is it, about 300?
275.
275 events, right? So this is an incredibly rare cancer. So I just think it's worth having that in context, that even if we're talking about an effect, we are talking about, relative to the size of people who consume fruit and vegetables, a small effect.
Right. And I think the authors address that. They talk about that kind of.
Maybe not a small effect, but a small total relative to the baseline, which is incredibly low.
Right. And I think the authors address that. Yeah, no, I understand. And I think the authors address that in a nice way, kind of talking through, as they talk through kind of the limitations of what they could really do. And the challenge here is that I don't know what a better design would be to look at glioma, right? Like this would be
case
kind
control
of
study, maybe, but you'd still end
right.
up with the same number of cases. Probably you'd end up with more, but probably not many more.
Probably, and here you have longitudinal data on these dietary factors, which you maybe would not have in the same way with the same quality recall and a case control design. So it has a lot of strengths, but it's challenging. And I agree that there is not much biological plausibility to think if there is a relationship between these pesticides and glioma, that it would only manifest in women participating in the first cohort and not in people participating in the other two cohorts, because you'd obviously expect that if there's that if there's a biological effect, that it would cut across people regardless of when you joined this study. So that was interesting too. I think, pesticides also consist of many classes of chemicals. It's not like one unilateral chemical. And the authors here, what was kind of cool is that they were looking at a couple of different types of pesticides that are kind of more established to be carcinogenic. But the pesticide composition on a piece of fruit has changed a lot over their study period. And people's dietary patterns, we were just talking last time about kind of fruit and veggie consumption, and people's dietary habits have changed also kind of over the course of this study. And so I like the way that they tried to use as best as possible kind of real-time estimates. But again, there's a lot of misclassification.
A lot. In
terms of what actually was on that piece of fruit that someone ate, that strawberry in 1985.
Exactly. So I should back up and say I think the authors did a really good job with what they had. I just think there are limitations to what they had. And as you say, I think there's a lot of opportunity for misclassification here. So it isn't just the misclassification. So there's misclassification in what you consumed, right? We know that the fruit frequency questionnaire has been validated, but I still think there's a lot of variation in what people eat, how they change over time, and how correctly people report or know what they ate. So you have that. Then you have on top of it, now we're going to apply essentially an average value of pesticide consumption onto the already mismeasured, mismeasured in quotes, because it's, maybe on average is fine, but already mismeasured food frequency. And you have a lot of potential variation. Now, I can't think of any reason why that would do anything but bias towards no effect. So maybe that's some of the explanation here, is there is an effect and you're missing it because it's not a huge effect and you've got so much random noise in the measurement that it's biasing towards the null. But then I wonder what explains the protective effect that they found in one cohort. So
in two cohorts, right? I think.
Was it two? I thought it was just one.
Oh, no, sorry. It was just one. And so I didn't talk about this in the introduction, but they kind of claimed a null effect. But on the kind of hazard ratio estimate, it was, the estimate was 0.52.
Yeah. So think about this. So if you flip that, it's essentially a doubling in the reduction in risk. So part of me says, well, they interpret that as null because their confidence interval is really wide, from 0.19 to 1.45. That is very wide. On the other hand, the majority of the consistency of the data is with protective effects. Right. So if you thought this was a really good study, you would interpret that to say, well, could be Could be null, could be harm, could be benefit. But, on average, if I had to bet, I'd bet on there being a protective effect. But then what explains that? Why would we expect a protective effect? And that's where I think it also gets interesting, because it also strikes me as plausible, and they say this right in the beginning, that there is some plausible rationale for a protective effect, because this is not a single intervention. I mean, intervention is the right term, but you know what I mean, in the sense of you can't consume the pesticide without the fruit or the vegetable, and therefore there may be protective effects of the fruit and vegetable that are competing with the harmful effects of the pesticide, and those may, on balance, in some groups, depending on age, depending on whatever it is, time period of exposure, the amount, one may outweigh the other. And so it's just a really interesting puzzle to try to tease out.
Absolutely. I mean, this is in my view, one of the most interesting things about environmental health is the idea that no one is exposed to one exposure in exclusion. And life is a bucket of exposures that interact with each other in complex ways. And sometimes we try to model elements of those interactions. Sometimes we look at the exposure unilaterally as if it stands alone, and it doesn't matter what vehicle the pesticides are. If the pesticide is on a really nutritious item, that obviously could play into the effect of that compound on health. And so I think, this sort of study, to kind of take it to a different level, it would be really interesting to look at some of those like mixtures statistical analyses to try to look at kind of more comprehensively, what are the mixtures of chemicals, how could they be quantified, and then in a bigger kind of cumulative, focus, kind of what are the kind of consequences of these mixtures in light of the health benefits of eating fruit and veggies, which are substantial.
Yeah, and I suppose the one other thing that I would say here is, so obviously causal inference from observational data is hard, and so because of that, we focus almost exclusively on a single exposure outcome pair, or occasionally two exposure outcome pairs. But if you actually want to think about policy, if you want to think about what we would do about things, we need to look at the bigger picture, because fruit and vegetable consumption is really important for cardiovascular health, for respiratory, for all kinds of things. And so we wouldn't want to say, well, just because we find that there is an increase in risk of some cancers in relation to fruit and vegetable consumption, but overall, you're actually going to live a longer, healthier life if you consume more fruit and vegetables. And what we need to do is not encourage people to consume less fruit and vegetable. We need to think about how do we minimize the pesticide ingestion that goes along with it. We sometimes lose the bigger picture. Now, I don't think we'd lose the bigger picture in this case. I'm just saying, I think in general, because causal inference is so hard, it forces us into looking at a very isolated incident. As we said, the risk of this cancer is incredibly low overall, and therefore, we don't want to draw conclusions based only on just thinking about its impact on one outcome.
Right. I think that's totally true. And I think also one of the things I was reflecting on with this study is just glioma as a disease, which I know largely from the TV show Lenox Hill. I don't know if you've ever seen
Never
this
seen
one.
it.
It's a good one, a little plug for it. But one of the doctors in the show is a specialist in glioma. And so in talking through kind of his work, this is kind of like a reality medical show, has talked about how over like 30, 40 years of research into treatment and, kind of medications for glioma, they've extended life by only 6 months. And so it's a particularly difficult to manage, devastating diagnosis, and the causes are largely unknown. And so I could understand why the authors took this deep dive into glioma, because they have tons of data for nurses' health and kind of, why glioma and pesticides, kind of this combination. And so I think part of what drove that was this like specifically terrible nature of this disease. Yeah.
So just to back up here, I assumed when you named that show that this was a drama, but now I think you're telling me this is a reality show?
Yes.
Yeah,
it's like
I can't watch those.
No, it's like some of it is probably kind of scripted, but it's largely unscripted.
They sell a narrative and all these things for sure. So it's never just reality.
But this is the heroic doctor who's treating gliomas.
I can't. My wife loves those. I can't watch them. And the worst of all is Dr. Pimple Popper. Do you know this one?
No, that sounds gross.
It's disgusting. It's I can't watch it. Nick, have you ever watched this? You know what I'm talking about? It's gross.
Oh, I have not seen this. Okay. No, I'm disturbed just hearing about it.
Lipoma is the word that comes out of that show. One last point I wanted to ask you about is, what do you think about use of quintiles?
I've used quintiles in my own research. I mean, I think...
So for the audience, for anyone who doesn't know, quintiles or quantiles or whatever it is when you break the data up into different exposure levels, not based on any specific value of any amount of pesticide that you consumed, but we just divide the data up into equal groups. So if the median value, median value is 100, then we could cut the data in half at above and below 100, or if there are other stratification values that put people into equal groups, we do that. My concern with quintiles is is always that they don't, or any of those approaches, is that they don't correspond to anything biologic. There's no reason to think that the highest versus the lowest corresponds to any necessary meaningful difference or above some threshold that we think is important.
Right.
And so it could be that the differences in the different cohorts relates to the fact that the distributions of the consumption are very different, and we're not looking at the exact same thing.
It could be. I mean, I think the quintiles or quartiles, I mean, they're useful when we don't know what the threshold of harm is, where we, and this is one of those examples where it's not as if, there's an understanding that over this level, this is really what puts you at risk, or over a certain level, this becomes carcinogenic. And so in the absence of having that information, the quintiles kind of allow you to not blur, but kind of blur. Like instead of the alternative would be to kind of use this data. If you can't use it in a dichotomous way, it would be to use it continuously. And in that continuous use of the data, it assumes that there might be a small increment change, that you're hypothesizing there is not, that you're kind of making the hypothesis that increment of change is not something you'd see continuously, but it is something you'd see over some threshold, but you don't quite know what that threshold is. So you're just going to say it's the top, however you define that based on how many people are in your study. And so there can be justification for using that approach. And I think I've used it in environmental health data, and I think it's it's not uncommon to do it, but it does have challenges, definitely. But it kind of leads into these exposures or even outcomes where there's just less certainty about what it really means biologically.
Yep. All right, let's move on to our second segment, which is the deep dive, where we're going to talk about the rise of the preprint. So this was an article in Nature Medicine called "The Rise of the Preprint: How Rapid Data Sharing During COVID-19 Has Changed Science Forever" by Claire Watson. And it's an article that I think makes some fairly unsurprising to those of us who have gone through what's gone on during the COVID pandemic. So unsurprising observations about just the fact that preprints, these scientific articles that get published on a server prior to peer review, some of which never go through peer review, but some of which many of which do end up going on getting published, but have had during the COVID pandemic an outsized impact, I think, on news coverage, media, and I think to a certain extent even policy, because everybody can access this and it makes a splash, but it hasn't actually gone through the peer review process. Now, we on this program have talked many times about our qualms about peer review, but I'd still rather have peer review than nothing before we start to at least screen things for what are in the realm of what we take seriously for rigorous science. Again, not to say that things that are on preprint servers are all bad. They aren't. Many of them pass the peer review process, but it's just being on a preprint server alone doesn't give it any kind of stamp of approval, even if that's a very, very weak stamp, as we've talked about many times. So this is happening. There is pretty much nothing we can do about it. Preprints existed before the pandemic. They were largely used in the physical sciences for a long time. They were not used in epidemiology and public health until I would say 5-6 years ago, when they started to come into favor, and then the pandemic hits and then they explode. So they say a staggering 19,389 articles about COVID were shared in the first 4 months of the pandemic, a third of which were preprints, unvetted and unfiltered for all to see. But it's also exposed the inner workings of the scientific process to a new audience and laid bare the best and worst of pandemic research. I agree with that. So they note there have been some huge success stories. So there are certain drugs that have been put out on these preprint servers that have turned out to be really useful. Others, studies on things like hydroxychloroquine and ivermectin, which have been incredibly harmful. And the problem is you've got a system that was designed for scientists to be able to communicate and access information faster and in real time and get a more broad set of critiques that can also be used by bad faith actors. I hate the term bad faith, but I'm just going to use it because I'm quoting them here, who jump on complex science or shoddy preprints to advance their narratives. And I do agree with that. So the question is, where ultimately do you come down on preprints?
Yeah, it's a great question. I feel like on balance, I think preprints are a good thing. However, they do have this in a very negative underbelly of, and it's sometimes I would imagine it's people who have a motivation to spread a particular message, and they view this as a vehicle to sharing that message through improperly conducted science or, other kind of sharing other problematic or falsified data. And this is viewed as a mechanism to do that. I think there's also kind of legitimately sometimes the value of peer review does come in, and there can be someone where there's a mistake or there's a misinterpretation, and maybe hopefully that might be picked up during peer review. But I think, the author here talks through kind of some of the successes of preprint during the first year of the pandemic and then some of the mega failures. And I would like to believe that the successes had public health benefit as it related to kind of very quickly sharing the genome of the virus and, kind of when there were clinical aspects that improved patient care. Remember, the kind of turning the patients from back to front or certain medications, that those could be shared very rapidly and could deal with the challenge that we had this fast-moving public health crisis, and science in its best form is slow and doesn't adapt very well to needing to move fast. And so sharing of the information, I think on balance probably is for the better, but it does have this kind of dark underbelly of, people being able to use this modality to share things that are either blatantly untrue or things that are incorrect, even if the motivation is not to share incorrect information. It's troubling, but yeah.
Yeah, so let me ask you this. Do you think that the progress in the pandemic would have been slowed down if we didn't have preprints?
Probably. I think the preprints, the best case scenario for preprint is that they allowed scientists and doctors and people who were making decisions to be able to have rapid access to data. And sometimes that was bad quality data, but oftentimes it was good quality data. And it allowed people to save lives by seeing that data sooner rather than later. And so on balance, yes, I think it was helpful. And I think there are some clear ways where preprint is beneficial. I think the author made the point that very few papers change between preprint and publication, which goes back to your earlier point that's not always clear that peer review kind of really gives this stamp of quality that we might hope that it does. But there is some value in speed.
Okay, so you believe that on balance, that if we hadn't had the preprint servers, that we would have been doing worse during the pandemic.
I think lives were saved by preprint, but lives might have also been lost by preprint too.
So this is the problem.
Right,
we would have to weigh the positives and negatives, because I do believe that. I believe that there are lives that were lost because of bad data put on preprint servers that fed into narratives around
vaccination or hydrochloroquine,
against vaccination or in favor of drugs that either don't work at all, or if they work, have small benefits, and you wouldn't want to forego vaccination because of them. You'd have to weigh that, and I don't know how to do that, or if anyone is trying to do that, but I think there is, an evaluation that needs to be done to really try to figure that out, because I think it does matter.
Right.
So you believe, you said, this allows doctors and scientists to access data that they wouldn't be able to otherwise access until they'd gone through the peer review process, and that slows us down. So then why not have preprint servers that are access limited to those communities? I mean, what about that argument?
Right. I mean, I think the challenge here is that preprints almost become an opportunity to crowdsource scientific findings among people who maybe don't understand how the study was conducted or don't understand the data. And it runs into that problem, like we've talked about before on this podcast, the idea of, how do researchers themselves draw their own conclusions on the basis of their work? And Should they? Can they? And what if other people draw different conclusions? Or what if the quote-unquote true conclusion from their research is not the way the researcher concludes at the end of their paper? And so it opens up all of those challenges in terms of, I don't think there's, I'm not sure there's a mechanism to say, like, you have to have a university credential to be able to access a preprint. But it does open up it makes it more like crowdsourcing and kind of public reflection of information. And that has all of the challenges with any kind of publicly available data or publicly available science, with even the diminishment that it hasn't had other professional eyes on it.
Yeah, and I want to make it clear, I'm not arguing for limiting access to preprints. I think I'm just trying to play out the options here. It does strike me that the problem would become that if you limit access to preprints, that information is going to be shared outside of the community, right? People are going to, if they have people with nefarious intentions will then take the information and then share it with others, and then it will essentially do the same thing, but it will look worse because it will look like you were trying to hide that information that was detrimental, and so that would sort of feed into the conspiracy theories. So I'm not sure that limiting access necessarily would improve the situation. In fact, I could see a rationale for how it might, in fact, make things worse.
Right. And I think an alternative to preprint is kind of the rapid review process, which I've seen a lot of the ID journals pick up. Especially during the pandemic. A number of them had them before, but kind of increasingly during the pandemic, where it's like, either the editor makes an executive decision about whether or not to accept the paper without sending it out to peer review, or it's peer reviewed minimally, where they say, okay, reviewer, two reviewers, you have a week, send it back, and then we want to make a publication decision.
I remember those. Yep.
Yeah, I mean, I've had papers that have been part of those processes. And as the researcher, it's kind of unnerving because you're like, oh, this was just the editor who made the decision by himself. It has the stamp of peer review. But it kind of wasn't peer-reviewed. It was just the editor. It was like an editor acceptance. And the goal of that kind of diminishes the need for the preprint because the paper is actually out there faster, but it also doesn't allow for kind of the thoughtful peer review that we, again, in the optimal circumstance would hope for.
Yeah, in the same way that we didn't really marshal all of our resources to deal with the pandemic. I think this the partly because of the way that the information, scientific information gets disseminated is decentralized. We didn't have a mechanism for this, but we didn't marshal all our resources to deal with the vast amount of science. So what you could have had was we could have had an emergency, get together of all the journals to say we commit to a fast screening of all the COVID-related articles, and then once we screen them, and we'll employ a whole bunch of people to do that, and then once we've screened them, we will send them out for a 1-week peer review. So the total time from submission to acceptance will be, a 2-week period, with then it being put online in its current form. Right? We could have tried to do something like that.
Right.
I'm not even sure that would have worked though, because the volume was so great. I'm not sure we could have ever met the demand to actually do something like that.
And the professional, capacity was so diminished. I mean, as people in the field who get asked to review papers, like we were home with our kids as well for the first 6-8 months of the pandemic, simultaneously trying to work full time. And so the human resources were limited.
Yeah. And the second part of that is peer review. I mean, we're already inundated with peer review requests. This was before the pandemic.
Right.
Now, all of the people who are best positioned to do the peer review have no time because they have thrown themselves into the science to conduct the science 24/7 to be able to generate the good information. So they're not available. So then it gets pushed down to people who have less substantive experience to be able to do that. It was a recipe for a poor review process. And there's no easy way to separate out the stuff that is promising from the stuff that isn't promising.
Well, and there's also the political agenda that plays into this that we really saw with the pandemic, and politicians or, just public personalities kind of promoting some of these findings because they seemed to work for my mom or seemed to work for me. And And
or it supported my desire to end lockdowns or institute lockdowns or end masking or institute masks, whatever it was.
Right. And so that became very tricky too, as that played into the meaning of the preprints and the speed of publication and how we communicated science during that period. It's very difficult.
Okay, last question I want to ask you. So we've sort of gone through the pros and the cons of preprints, and we've talked about also our concerns about peer review. The question is, are we better off with a paper that is a preprint that gets picked up by the media that may never turn into anything good, or a study that gets the stamp of approval of preprint, of peer review, that then gets in the media that is also a bad study? Which is worse? I mean, we know that peer review is letting through a lot of studies that are bad studies. Which one's worse? The one that's actually been gotten the stamp of peer review, or the one that didn't?
This is a terrible question. Like, which one is worse? I feel like, we also are in this environment now where science is really distrusted, and medical research and epidemiologic research, there's a lot of distrust, and there's a lot of sense that we just mess up kind of everything we put our hands on when it relates to this data. And so, to the extent that a peer-reviewed study later ends up being wrong, or there is some expose that shows that it was the data, analysis was shoddy, or the peer reviewers did not pick up something that might have been kind of glaringly obvious if someone had actually looked at it sat down and had the time to really look through it and look at it closely. That's bad for the field too, when papers come out and they have to be retracted. And that's bad also. And in some ways, that's worse, because that reflects publicly the failures of our system, although the retraction itself is a positive thing.
Yeah, I mean, that gets into retraction. Retraction is another tricky one, because we've talked a lot about, does something that turns out to be wrong but was done in good faith, should that be retracted? And generally speaking, my opinion on that is no, because every study is one of a distribution of studies that get done, and it all comes together. We don't retract the ones that turned out to be wrong, as long as we believe they were done in good faith and done fairly well. It could be that it was there was some bias that we just couldn't remove, or it could be this was just by chance one of the bad ones. But during a crisis like the COVID pandemic, I think there's more of an argument for retraction of studies that turn out to be wrong if they are highly influential, because then I think we need to say, this is not correct information. Stop citing it. Stop using this. And, that's a tricky one. But I'm going to use that point. I'm going to end this conversation and switch over to our last segment, which is our Amazing and Amusing, because my Amazing and Amusing comes from Retraction Watch. So it fits perfectly well with what we were just talking about. So this was an article I found interesting. It was published in January 20th, I think, of 2022 on Retraction Watch, and it was entitled Courage and Correction: How Editors Handle and Mishandle Errors in Their Journals. It was put out by a group of people, researchers, who have spent some time identifying studies, particularly in their case, I think randomized trials, that have mistakes in the way that they are analyzed. And they identify them. I don't have any reason to believe that this is their mission or anything. It could be that they just read a study and say there's a problem here, and then they go and then they see another one and they go to that author, or it could be that this is a goal they set out. I don't know the answer to that, but they find a particular problem that is common, which is cluster randomized trials being analyzed like they were individually randomized trials. So the idea here is a cluster randomized trial is when you randomize a group rather than an individual. You don't flip a coin and say you're going to get the drug or you're not. You flip a coin and say that school is going to get the intervention, like when we talked about the fruit and vegetable one. This school will get it. And the limitation of that approach is kids who are going to the same school, they're more like each other than kids who are going to different schools, and so their outcomes are more likely to be like each other, and therefore you get less information per person, and you have to adjust for that. You have to widen your confidence intervals using statistical techniques so that you have less certainty in your results. And I support that. I mean, so they identified a lot of cases where this is being done. They then contact the journals, and their experience, they talk initially about one in which they contacted the journal and they said, here's a problem. We think there's a problem. Can we access the raw data? And the authors give them the raw data and they say, okay, this is actually better than most situations because most of the time people won't actually cough up the data. So then they reanalyze the data and they find it does actually make a difference. One thing I left out was sometimes reanalyzing the data using the correct methodology makes a big difference. Sometimes it makes a small difference. And so you could argue in some cases it doesn't matter, in some cases it does. So they find in this case, it matters. The results go from statistically significant to not statistically significant. They then go back to the journal and say, here's a problem. And that's when they run into problems. So now the journals start to say, well, communicate with the authors on this, work it out, or they say, we're going to send it to the statistical reviewer who reviewed this and see what they think, or it just sort of gets pushed aside, or they say, you can write a response, but it has to be only 800 words, and so you don't really have enough room to get your point across. And their point here is, editors aren't really incentivized to correct mistakes, and they run into a lot of problems. I thought that was really interesting, but I also see another side to that, which is I agree with them. I think they're correct, and I suspect in a lot of cases it really is just a desire to have this go away. You don't want to be issuing a lot of corrections or potentially retractions. On the other hand, this is based on saying we believe there is something wrong with these studies because they did the wrong statistical technique. Most cases, not exclusively, but in most cases, when you adjust for the clustering that happens within these clusters, the point estimates do not move at all. There are cases where it can, but generally speaking, they don't. What changes is the confidence intervals. And so you can go from a situation where you have statistical significance to you don't have statistical significance. But I'm not a statistical significance person, right? So to me, I care about the precision of the estimates. I care about how wide the confidence intervals are. But it matters to me whether those confidence intervals are increasing dramatically or are they increasing a little bit, but they're going over the bounds of statistical significance. In some cases, to me, it matters. In some cases, it doesn't. And it seems to me partly this is based on a view of how we interpret data, what is right and what is wrong. So I can sort of see both sides of this. I applaud the authors for what they're doing. I do think they're correct that there are correct ways to analyze this data, and we should be doing that, and I support that. They also reference cases where there are just flat out mistakes, and those are different. Those are absolutely should be corrected. But I think there are some gray areas.
Right. It's an interesting point. I mean, I think also the kind of the way editors or outside reviewers approach a team where they think they've made a mistake. And, we were talking about some like a well-intentioned mistake.
Yep.
That they have this data set and they're doing this analysis and they didn't do something that maybe they would have or they should have done, but they didn't know they should have, kind of how is that approached in the field and say it's a student paper. And, is the goal to take down someone on the basis of that they didn't properly adjust for cluster randomization?
I don't, by the way, I impute no nefarious.
No,
I think these people are doing wonderful work. I'm supportive of them. I'm just saying I think there are areas where you could disagree.
No, and I think in the field, too, I think we could have a greater openness to other people reanalyzing our data.
Yeah,
and the idea that they would have an improvement over the way we did it and that wouldn't be presented necessarily as an attack on your integrity.
Yep.
That, it's the idea that we did this study and you maybe should have done something a little bit different and you didn't know it. And so we're going to kind of reanalyze your data, work together, and maybe your results don't really differ. Or like you're saying, the take-home picture doesn't change.
Yeah.
And most likely it's not going to.
Agreed.
I think that's hard because everyone gets defensive about their own work, especially after it's published, especially after it's on your CV.
Yep.
That it can be hard personally, I think, to take the idea that maybe we didn't do something exactly right.
Totally agree.
Kind of the iterative nature of the field and learning.
Yep. What do you got?
So I have something again very, very different, and this is an obituary. So not amusing, but an amazing career that I wanted to just note because it has affected me. So a management researcher died in the last few weeks. Her name is Sigal Barsad. She was a researcher at the Wharton School, the business school at the University of Pennsylvania. And over the years, I have been quite affected by her research, and it's not something that was always at the top of my mind, but I saw her obituary and I said, it's a shame. She was in her mid-50s too when she died.
Sorry to hear that.
And her research was about the importance of expressing emotion at work. And for me personally, I feel like when I started my career, as a woman. The idea was that, you don't talk about your personal life at work. It's kind of like, you don't talk about Bruno. We don't talk about Bruno, and we don't talk about our personal life at work. And you walk into your office, you don't talk about your kids, you pretend you're not pregnant until it's visibly impossible to do so. You don't talk about marriage, you don't talk about your relationships, you don't talk about divorce, you
Really?
bring and I think this was reinforced to me by my women mentors, that you will do better professionally if you just come in as your own self and you leave as your own self and your home business stays at home. And what was so interesting to me, and so I was reading this research as it was coming out over the last, 10 years or so, was that her work was highlighting the fact that organizations that did not ask people to do that, and in fact kind of provided an emotional support network among colleagues, that the companies did better. And this was kind of the take home, that they were more successful, the work units were more successful, in addition to people feeling more kind of better about their work lives and experiencing less distress about this kind of discrepancy about their work self and their home self.
Yeah.
The idea that it was good for the business bottom line, for companies to have a culture that didn't require that separation. And I think this was something that for women kind of my generation was particularly resonant, because my mentors, older women, very much could not discuss their personal life at work.
Wow.
And that was something that was expressed to to me personally, and I think to other kind of women in epi and public health of that generation, that you really couldn't talk about these things. You maybe went away for a couple of months and you had a baby, but then you were back and everything was just the same as it was before. And I think things have shifted. But I feel like my career, even in these early kind of decades of my career, has crossed over that threshold. And I think her research was really instrumental in bringing organizations around to seeing that there was an economic bottom line to kind of not having that distinction. So I was sorry to see that she passed away.
I'm sorry to hear that too. That's really interesting to me, because my mentors have been the exact opposite.
Yes, you're a man.
So you're 100% right about that, and I think that impacts the way I see it. But when I say that, like what I mean is department chairs, and it was for the whole department. So it wasn't just advice to me. It was advice to the whole department. In fact, the terms "bring your whole self to work" were said all the time. Mm-hmm. That doesn't mean, though, that doing that doesn't get experienced in different ways based on whether you're male or female. And so I can see that. It wasn't a culture I want to say raised in, but you know what I mean, academically. Right. But I don't know what the consequences of that policy or that culture were, whether they actually worked for everyone or if they just worked for some people.
Well, I think the idea, at least in my kind of early understanding of what it would mean to bring your whole self to work, is that it benefited men because sure. it made you seem kind of more agreeable and more willing to collaborate and kind of more well-rounded in a way that benefited you professionally because people wanted to work with you. But for women, it had the opposite effect because it made people think you weren't committed to your work or you didn't really have the time, or she's not going to be a good collaborator on this research project because look, she has a baby and she's just not going to be around even if, she's brilliant. So I think there was that gendered effect, and I think it has been changing in academia during the pandemic. And I think, and that's in part why I was reflecting on this obituary right now, is that I think there has been this motivation now, even if you don't want to, your work is at home, your home comes with you to work. And there has been this larger understanding of kind of the whole self at work. And I'll be interested to kind of watch to see if that maintains.
Me too.
Or if we kind of all go back into our bubbles of kind of no, home is at home and work is at work. So
totally agree. And there's like an Apple TV series coming out about this sort of like these folks who have their, I don't know how it works, that they have like something surgically done to their brains where when they go to work, they completely forget everything about their home life. And when they go home, they completely separate from their work life and they have no memory of what happens in between, which I think is an interesting parallel. All right. Well, that is the end of our program. If you got any feedback on this or any other episode, or you want to suggest a study or a topic for us to take on, you can tweet us at @PopHealthEX, or you can tweet me at @ProfMattFox, or Don at @DTheo1, or Chris @ID.Gill, or you can find us on the Population Health Exchange website at www.pophealthex.org. We want to thank Leslie Talalian, Assistant Dean of Lifelong Learning at the BU School of Public Health, for supporting the podcast, and Nick Guler for sound and editing. Thanks for joining us. We hope you enjoyed it, and we hope you will download our next episode.